Hello and welcome to today's webinar for mental health professionals collaborating with pediatricians, tools and techniques to enhance relationships and care coordination with pediatricians in your community, featuring Deborah Kissen, Ruth Lippin, and Lynn Sicklin. My name is Astrid Masvar. I am the Senior Education and Outreach Coordinator here at ADAA. Before we get started, I would like to go over a few items so you know how to participate in today's webinar. We've taken a screenshot of an example of the attendee interface. You should see something that looks like this on your own computer desktop in the upper right corner. You have joined the presentation listening using your computer speaker system by default. If you would prefer to join over the telephone, just select telephone in the audio panel and the dial-in information will be displayed. Please make sure you are muted during the entire presentation and your webcam is disabled. You will have the opportunity to submit any questions by typing them into your chat box located in the control panel. You may send in your questions at any time and we will address them during the Q&A session at the very end. If you registered and paid for CE credit, you will need to provide the 4-letter CE code in the webinar evaluation. The CE code will be shared at the end of the presentation and the link to the evaluation will be sent to each participant within 48 hours of this webinar. The post-test assessment will occur at the end of the presentation. The questions will appear on your screen and you will be given 5 to 10 minutes to complete the assessment. Once complete, please click Submit. I would now like to introduce today's presenters. Dr. Deborah Kissen is the Clinical Director of the Light on Anxiety Treatment Center of Chicago. Dr. Kissen specializes in CBT-based treatment to children, adolescents, and adults with a focus on anxiety and stress-related disorders. Dr. Kissen is an ADA member, a clinical fellow, and is co-chair of ADA's Public Education Committee. Ruth Lippin is a licensed clinical social worker who has had a private practice in New York City for the past 20+ years, specializing in the treatment of anxiety and related disorders. She is an active ADA member and is the co-chair for ADA's Child and Adolescent Special Interest Group. Dr. Lynn Sicklin is a psychologist at the Children's Center for OCD and Anxiety in Pennsylvania. She has been specializing in treating anxiety disorders in children and adolescents for over 20 years. Dr. Sicklin is an active ADA member and a part of the Public Education Committee and Professional Education Committee. In an effort to reach more children, the Public Education Committee, in conjunction with the Child and Adolescent SIG, created a PowerPoint presentation for therapists to show pediatricians called Anxiety Disorders and OCD, What Every Pediatrician Should Know. This webinar will demonstrate how to best use this PowerPoint presentation. You can find this webinar presentation at ada.org under the Research and Practice tab under ADA Publications and Special Offerings. Access to this PowerPoint is exclusive to ADA members but is available for download for today's webinar participants under the Materials tab on your webinar attendee interface. I will now pass the screen to our first presenters. There will be a brief pause while I do so.
Okay, I guess I have the screen now. Hi, everybody.
Yep, perfect.
Okay, great. Hi, everybody. Thank you for joining us today for this webinar. As Astrid said, my name is Ruth Lippin, and today, along with Lynn Sicklin and Deborah Kissen, we are going to talk about the Pediatric Outreach Project, which was a collaboration between the ADAA Child and Adolescent SIG and the ADAA Public Education Committee. The purpose of the project was to educate pediatricians as to what anxiety disorders look like in their patients and to give them some basic tools to treat it, as well as to teach them about the evidence-based treatments for these disorders. In order to do that, we created both a PowerPoint presentation and a brochure that can be customized to any ADAA member in order to transmit this information. So what we're going to do is today, first, Lynn and I are going to go over the PowerPoint presentation and mention sort of key highlights, and then and the best ways to use it. And then Deborah is going to talk about some fun and effective ways to get pediatricians interested in hearing this information despite their busy schedule. Okay, so let's see here. So okay, so this is the PowerPoint presentation. Anxiety disorders and OCD, what every pediatrician should know. Um, and then we have an outline, which first is the prevalence rates, the consequences of untreated anxiety. Then we discuss what pediatricians see when presented with an anxious child. Then we briefly talk about the DSM-5 anxiety disorder diagnoses, anxiety screening tools for the office, cognitive behavioral treatment for anxiety, and how to support families and reduce family accommodation. Okay, so then we move on and we talk about why that you should pay attention to childhood anxiety disorders, right? So they're common among many settings, and we show the statistic that 25.1% of adolescents between the ages of 13 and 18 years old will be affected by an anxiety disorder. We then have this, we then have this great lifetime prevalence of anxiety disorder slide. And then, of course, why should we pay so much attention to anxiety? The negative impact on educational achievement, delays in important developmental milestones. You know, we all know the child that can't go to sleepovers, right? Can't go to sleepaway camp. Associated with depression and suicidal ideation, increased risk for substance use disorders, and then a list of sort of the medical issues that can come about because of anxiety disorders. And then one of my favorite slides is this, right? So pediatricians are treating ADHD, you know, almost 80% are getting treated, and yet only 31% of kids with anxiety disorders are receiving treatment. All right, so what do anxious kids and families look like when they go to the pediatrician's office? Somatic complaints. 90% of youth report physical symptoms, and then we go into a list of the actual symptoms. The headaches, the stomach aches, the heart palpitations, the muscle tension, the sweating, trembling, shaking, and then my favorite, the sensation that something is just not right in their body. And then we talk about the behavioral symptoms, right? You know, how many parents come in complaining that my kid's missing too much school because of their stomach aches? My kid can't sleep. They don't want to sleep in their own bed. I can't sleep. I can't sleep in my kid's bed. And one of my favorite, excessive reassurance seeking, right? You know, I can't stand it if my kid asks me that question one more time. Frequent visits to the doctor's office. Requests for medical tests. There must be something wrong with me. And requests for medications from the doctors. And my other favorite, children and parents who are miserable with disrupted lives. All right, so the signs that the physical symptoms are most likely anxiety-based, right? Because, you know, we're talking to pediatricians, and they've been trained to look for medical, physical reasons. So the child's fine once they're in school, but mornings or evenings, especially Sunday evenings, are quite difficult, and the symptoms occur around academic or social stress. Then we go into the most common childhood diagnoses. 4, right? So we talk about generalized anxiety disorder, the worry disorder, the what if, right? We are late. What if we get lost? What if I fail my test? And of course, we have
So
our
I think as we know, we tried to cover the anxiety disorder diagnosis, but not the DSM-5, but how kids would talk or parents would hear in the office if they're talking to the pediatrician. So the what ifs and the reassurance and avoidance are something they could easily recognize without understanding the diagnosis.
Absolutely. Good point. Right. So this is right. So, they keep asking me the same question. They won't go out. They won't go on play dates. They don't want to go out during the weekends. They won't go to a movie, right? And then, of course, the catastrophic and negative thinking. So again, with social anxiety disorder, we talk about the actual symptoms that parents and pediatricians will see. The avoidance of eye contact. They don't want to go to school. Rumination about interactions with their friends, and just plain not just not wanting to interact in sort of normal developmental social ways. Separation anxiety, right? Again, what parents and pediatricians are seeing, they don't want to be away from their parents. Nightmares. Again, reassurance, panics if parents are late for pickup. It drives the mother or father crazy by following them around the house. Sleep is often a nightmare. Again, social activities are limited. Then we talk about OCD, intrusive thoughts. The kid that lines up all their stuffed animals and needs their room just right. Fears about doing something bad, the checking, the superstitions, the reassurance, and the confession compulsion. Then we briefly mention other childhood anxiety disorders, childhood PTSD, panic disorder, health anxiety, and then, of course, the specific phobia, right? The blood, the needle, the vomit, the dog phobias.
Ruth, can you hear me?
Yes, I can hear you.
And this is a question for Lynn also. When presenting this material to pediatricians in your community, I'm in Chicago, you're in New York and Philadelphia, correct?
Right.
Yes.
What trends are you seeing in terms of the pediatricians in your community? What diagnosis and disorders do they seem the most interested in, and that they're getting the most patients struggling with symptoms? Have you noticed anything of late? Any changes?
Well, I think what Ruth brings up, I think what pediatricians struggle with, we have a whole bunch of kids come into our practice on antacids and other anti-gas for a year, like maybe a year or 6 months. It's not helping the actual stomach ache, but the pediatricians are kind of giving that as a first line. So I think the belly aches and the something's wrong, and the health focused anxiety is what I hear most from the pediatricians. We are fortunate in that we've collaborated with a number of pediatricians for a while, and they're actually really good at recognizing the more subtler forms. Certainly separation anxiety, they seem to see and recognize, and they can tell, that parents aren't being able to kind of, leave their kids at all, or the drop up. So I think that's what I hear the most, the belly aches, health focus, and, and they do get worried sometimes too. I think they mess up shyness a little bit sometimes and call social phobia something they'll get over, or just shyness. And I think all of us know we don't treat shyness, a kid who's actually comfortable with being a little bit quieter and the listener. But we have a lot of parents who've expressed concerns to pediatricians for a long time, and the pediatrician, some will say, don't worry about it. It's normal. They're just shy, when they're really limiting their life. So, but Ruth, I don't know if you have other.
Yeah, I mean, I also think we see a lot of sleep issues. Right? Parents are coming in a lot about for sleep, and also in addition to that, a lot of anxiety about their children's social life, right?
Yeah.
So, so social anxiety among the kids.
And we'll come back to it, but pediatricians do a really good job at starting the sleep work, and they actually can do quite a bit themselves that are really helpful, and then they kind of refer when that doesn't work, I think.
Yeah, no, I agree. I think that that's really true, right? And I think the interesting issue, one of these is, the social phobia, right? When is it just normal shyness, and when is it something that needs to be treated? I think you see a lot of anxiety, at least among New York parents, around that. So, yeah.
Thank you.
Okay. Sure. All right. So then we end this section with the bad news and the good news, right? That anxiety is not just a phase, which I think a lot of parents and potentially pediatricians want to believe, but the good news is that it's highly treatable. And that brings us to our next section that Lynn is going to talk about. Better and easier to treat early. Okay, so Lynn, I'm gonna.
Yeah, and so we also as a group felt it would be important to provide pediatricians fast and easy screening forms that they could use in the office, because all of us know if you've brought your child to the pediatrician or you've talked to friends who are pediatricians, they are tight for time and they're trying to do so much in one session. Many of them already are doing screenings for depression and ADD as part of their well visits and other things, but sometimes the anxiety disorders are missing. So we wanted to just let pediatricians know that there's some very short, fast, but very well validated instruments. So the best, Ruth, can you help me with that? The slide? So the SCARED is a longer version used in research, but it's a child and parent self-report that's very well validated, and it does screen for the primary anxiety disorders, but you'll see there's a 5-item one that can be used in the office compared to the 41 items that's best. So these 5 items really identify kids with anxiety of significance, at least to follow up. So we wanted pediatricians to know that a score of 3, above 3 indicates clinical anxiety, but it's really fast, right? Being alone, worry, frightened for no reason at all, scared to go to school, and excessive shyness. They sound simple, but they identify kids to follow up on. Ruth, can you do the next one? And then the same thing was we wanted them to have quick and easy tools for assessing a family accommodations. Can you go back to the one? Yeah. So I think a lot of us who treat child anxiety are talking to families about this issue as a way to actually help anxiety, or what makes anxiety stay around. And it helps to think broadly. When I shared, Deborah, when I shared these examples coming up with pediatricians, they really loved having these examples. But accommodation is anytime a parent changes their behavior to help the child avoid anxiety. And of course, we're working on treatment goals of actually supporting a bit and modifying expectations, but certainly we want to be aware of any way anxiety is ruling decision-making for family or child. Ruth, can you go forward?
Yep.
Thanks. So these are some that are simple and then some more exaggerated, but it's not that we don't see. Sleeping next to a child who's afraid to sleep alone, super common one. Answering a lot of worry questions. Again, parents don't understand how answering questions actually could be accommodation, and yet it is and maintains anxiety. Johnny gets very anxious about being hit by lightning on a rainy day, so we stay home and watch movies instead on rainy days. I have a lot of families who, like, the kids want them to run home when the gray cloud comes over the pool, not when there's a lightning risk, which of course we say we are going to go in a lightning risk, but they want the family to go home when it's gray. And this is a more extreme one, but I think we've all heard it. Sally hates going to school on Mondays after a nice weekend at home, so I changed my work schedule. Now if she has a tantrum about going to school on Monday, we can stay home together and help the transition. Again, more extreme, but not out of context of what happens sometimes. Next.
And I just want to add that pediatricians really love these examples, right? Because this is what they hear every day in their office.
Yeah, so they really liked it. And here's some more subtle ones. We can't go out anywhere without Max having a tantrum and wanting to go home. I'm so tired of not being able to do things on weekends. This is a real common one. We have friends that have a dog, and we have to make sure the dog is out when we go to the house. Right. Sarah gets scared at movies, so we just don't go to movie theaters. We watch movies at home only. And Mary follows me around the house, and I can't get anything done. So the really cool thing is there's a family accommodation scale that's brief. Again, five items for parents and for kids. Oh, this is not it yet. So there's a measure in a second, but these are really easy. Can you put them all up, Ruth? Really easy screening questions that I think pediatricians already probably ask, but really helping them ask. And I think clinicians, if you're not using this, I love these.
Yeah, this is
How much
great.
time is consumed by your child's anxiety? How much time is consumed by your family accommodating your child's anxiety? How much is family life impacted by the child anxiety? And I really want parents to think not just about the child needs, but about sibling needs and their own needs. Like, are you late to work, right? Are you deciding what you do because your child doesn't like anything new? So you're not going exploring, on the whim on a Saturday. How much is your child restricting his or her activities, of course, and how often do you provide reassurance, because your child is anxious? So those are easy ones that a pediatrician could ask easily in their normal, kind of routine.
And I'm going to add these to my intake form. We touch on when new clients come to us a little bit with accommodations, but I really like how those questions break it down. So thank you so much.
Yeah, I think it's a really good intake. Questions for me. I do most of them, but they reminded me of other things I'm not asking that I could. And the next slide is the actual measure. It's not 5 items. I was wrong. I think it's a few more, but there's a parent version and a child version. I won't read this so much because you've heard some of them. But here's the child, and the kids are good at answering these too. How often does your parents reassure, like tell you that you don't need to worry, right? How often does your child do your parent give you things to make you feel better when you're anxious? So it gets the very subtle accommodations and the stronger ones, and I think it increases awareness of treatment targets for us. So these slides, I think, could be helpful for clinicians, but it also might be a way that a pediatrician could give this before a visit and then look for high scores on it and not take a lot of their time, but still catch important pieces of anxiety. So next. Okay, and then we decided we just wanted to help pediatricians understand the focus of cognitive behavioral treatment. And we wanted to talk a little bit about how cognitive behavioral treatment has changed a bit in the few years, because some of them know the more traditional CBT, which we still do a lot of, but we're also trying to model a way of relating to anxiety that I think, again, pediatricians could coach parents and kids, even without us, on the lower level cases, situations. So can we go forward? Okay, so the main goals, is for children to have rich and full lives of engagement rather than avoidance, to teach children not to avoid situations and activities that cause anxiety, to teach children and parents not to be afraid of an anxiety. So this is really important. The presence of anxiety seems like a problem, both to kids and parents, that must be gotten rid of. And we actually are, trying to say we don't want you to have these high levels and frequent anxiety that you have, but the presence of anxiety is not the problem. And if we're not afraid, it actually passes much more quickly. And then the last point, I can just, without going back, says to teach parents and kids to accept, allow, and predict the presence of anxiety rather than to be upset and surprised by it. So CBT treatment itself teaches a lot of, as you know, psychoeducation about the body's reaction to anxiety, also to minimize fear about the reactions, to help kids understand how they think when they're anxious versus how they think when they're not scared, and the differences that they notice. Coping techniques to talk back to anxiety, and exposure, facing fears step by step. Next. I'm not going to go into this too much, but we thought that pediatricians would really like this overall overview of the components of anxiety, and again, examples, of exaggerating risk or what if questions under the thought dimension, the feelings, and to know that anger and irritability can come up a lot in anxiety. It's not just quietness and fear and worry. The physical symptoms, and then behaviors to kind of look for and to tell them. We teach families and kids the components of anxiety.
Lynn, one small comment, just as I'm in awe of this beautiful presentation and how great the resources are, this is also material, this talk that we're giving now for pediatricians, but schools, in my community, school counselors often ask me to come in, parent groups. So this same material really has a lot of audiences that benefit.
I think it could be a great 20-minute parent education for a school or training. I think you're right. Yeah, we hoped it would be used more, globally, because we just feel like we wanted to create a good-looking, simple but informative overview of the material. Yeah, so I'm going to use it that way too.
Me too.
So the psychoeducation, is about anxiety being a protective mechanism and warning us for danger and threat. But just knowing that sometimes with anxiety, the alarm goes off too easily or too sensitively, and that we teach about the fight or flight response. Again, I think pediatricians do that actually quite a lot of explaining to kids and families what's going on about the fight or flight. And then we're trying, and I think the pediatricians that I work with is to help families know that the physical sensations are not dangerous. The stomach ache is uncomfortable and it might bother you in the morning, but it's not needing treatment, right? It's not needing necessarily medicine, and that it's not necessarily dangerous, but I'd like to help you have less stomach pain. And that we teach a lot about the connection between the brain and anxiety. And next. And then I'm not going to go through these, but we just thought this was a really nice example of thinking traps that we teach kids and families about. We tried to pick the best ones that we use a lot, and we tried to give examples underneath that, because sometimes, you get examples of fortune telling, but what does that mean? I know I will fail the exam, or I know I will have a bad time at camp. Some examples of overgeneralizing, and again, a real common one in my practice, the mind reading, especially in social anxiety, but also in the worriers. The teacher thinks I'm stupid, right? So we gave that, and the next one is some more thinking traps.
Yep.
And again, I think labeling is one families hear a lot, like, I'm stupid, I'm bad, right? I'm worthless, filtering. We didn't have some examples, but that's a little clearer, only noticing the bad things. And then some examples of catastrophizing, again, the subtler version, none of the kids at camp will like me, versus like, my mom's gonna die. the big catastrophes and the smaller ones, but all that matter. Okay.
All right, next, talking back.
So cute. That's so cute.
I love this one.
So
this is still me, Ruth, or is this you? Ruth, is this still me?
Oh, yeah, I think. I think.
Okay, I'll do this one.
I'm happy to do it too, whatever you prefer.
Yeah, no, I'll go ahead and do this one, and then maybe I think we switch soon. I don't have the numbers in front of me. So we all have talked a lot about externalizing the presence of anxiety and separating the child as a child, say John, from his anxiety experience. Kids like to call it, kind of funny names. I have a wall in my office right behind me where I hang up all the pictures, and it's my best decorating and best selling idea in my office. Parents love it as much as the kids. And I have here Worry Penguin, Mix Up Master, The Voice, Worry Brain, Fuzzy Brain. Kids, some like to do that and some hate to do that, as you know. Sometimes just like to call it worry, stress. That's weird, that's babyish, whatever they care about. But we're trying to help them separate, and that they can boss their anxiety or be aware of it. You're a big bully, I'm in charge, not you. I don't have to listen, when you threaten or warn me. And then also, some people are having more debate about fighting anxiety, and maybe we have to actually help kids be more compassionate. Like, I know, you're trying to help me, but I'm really okay. There's no danger here. I kind of go with the kind of kids, preference.
Right.
So that's the talk back to anxiety. But then we also wanted to get in a little bit more where our field is going about the relationship to anxiety and interacting with it differently. So I'm sorry, Ruth, I don't have the numbers on the slides in front of me. Are we switching now? Or?
Bill, I have a switch at working with families. So, but
yeah,
I'm happy. So you can do the building.
I had the hierarchy, and then you had the families, right?
Yeah.
Okay. So we also really wanted to give examples of a behavioral hierarchy, because that's hard for clinicians to create. Sometimes it takes creativity and thought, but we also wanted pediatricians to know how we might work on something. We also wanted to demonstrate that we show and model for kids the science, right? Is that the anxiety will rise when you challenge anxiety, when you don't do the tricks, when you don't get the reassurance, but that it will reset. And you won't believe us until we try and do something differently and model and have the experience of it. That's why we have to do exposures rather than just talk about it. You have to see that that's true, or else, you're not going to believe it. And so we created a few hierarchy examples here. Ruth, if you could do the next one. Oh, did we miss? Okay.
No,
Sorry.
this is just we just showed before that. We just showed the slide that shows why ERP works, right?
Okay.
And
Great.
this is the goal of ERP: rewiring the brain, overcoming fears, avoidance, and then we had some.
Yeah, we wanted to pick just a few hierarchies since we didn't have a lot of. We wanted to think what the pediatricians might see the most, so we definitely thought a separation one would be important, starting like we often do for a child who just can't be in a separate room, even if the parent's in view, without calling out. And so they could see we could start very small, but move pretty quickly up the hierarchy to more time alone in a room where you can't see a parent in view on the second floor. So we wanted them to see an example of a hierarchy that we might use of a child who's afraid of not knowing where the parent is. And our other favorite, vomit phobia, which they see a lot, I think, also in their office, their parents first coming in because the child's freaking out about vomiting. We want to show them our lovely hierarchies of the stuff we have to do with vomit phobia to kind of watch experiences, hearing sounds, speaking words rather than avoidance. And so we kind of gave some examples of a vomit phobia hierarchy so they could see what that is like. And then we've also thought bedtime fears, because like Ruth said, I have a lot of great pediatricians who are actually doing behavioral interventions around bedtime fears and sleeping, and they actually are often taking care of it, the sleep hygiene, and they do a lot of this stuff. But we also wanted to show how we might be working with a kid and family in a systematic way. But a lot of times we think pediatricians might tell parents to try this 15 minutes, in sleeping with them, staying with them until they're asleep, but they do it for 3 months. Whereas I think a lot of us would do 3 days of staying until the child's asleep, and then 3 days of staying till they're almost asleep. So they could see that learning has to happen kind of moving along relatively rapidly while still breaking it down into manageable steps. So we were kind of just showing them a hierarchy of bedtime fears. Okay.
Okay, right. And so then we talk about working with families, right? Because that's what pediatricians have to do. They have to work with families. So the first thing
I like that slide.
That's a great slide. We have to thank Ellie Leibowitz for some
This is
of these
Ellie
slides.
Leibowitz is great. So are the family accommodation examples, which are great. He worked on this a lot. So.
That's right. So I love this slide because parents really come in confusing support and accommodation, right? So this is the introduction to the distinction, and then Ellie had this great slide that we used, which is, what is parental support, right? It's accepting that the child is anxious, right, and believing that the child can tolerate it, and that's what equals support, right? It's not, oh, Janie is so anxious she can't sleep alone, let me sleep in the bed with her, right? It's rewarding Janie for sleeping alone and supporting her in those efforts. And not being afraid, right? A lot of parents come in being terrified of their children's anxiety. And then we talk about how to address family accommodations, right? We have to educate parents about the nature of anxiety. Parents, as I just said, come in really afraid of their child's anxiety. Help them coach their child through anxious moments. You can do this. You've got this. Nothing terrible is going to happen. And then, really the key here is starting to talk about not using avoidance as a strategy. And really, if we can teach pediatricians to talk to their families about that, I think we can make huge headway into reducing anxiety disorders and not letting them build. Build brave behaviors, encourage parents to help the child face their fears rather than avoid them. Again, I think parents' instinct is to keep their kids safe. I just heard about the snowplow parent, right? Now we're done with the helicopter parent. Now we're the snowplow parent that is, making sure, leading the way to make sure there's no adversity in a child's life. So really just talking to pediatricians about that, I think, is just enormously helpful. Support self-efficacy. And, something I face a lot in my practice is getting parents to let their kids do things that scare them. So really having pediatricians talk to parents about that. This is another great slide, right? Parents are always like, no, it's not scary. You can do that. Oh, it scared you, but I'm sure you'll be okay, right? Oh, he can't handle that stress. It's hard for him, but he can learn to manage this. Pediatricians love these type of slides. And then finally, moving along to helpful parent responses, right? Parents often mean well, but they don't often transmit that. So empathy first. I'm sorry, this looks like a tough morning. And then coping, right? Anxiety or worry is trying to trick you. You are in charge, not anxiety. This is stress, anxiety. You're not in danger. I mean, imagine how many anxiety disorders we could nip in the bud if parents really talk to their kids, right? Right? You just had a scary thought, feeling, or picture. You got this. This feeling will pass, right? Go have fun. Okay, and then Lynn, I think you were going to briefly talk about medications. Actually, we only have 20 minutes left, so maybe we should.
Yeah, we should get going. So we just would want to say that we actually created an Ellie Leibowitz, who's very integral to this. Ruth, Ellie and I took the lead on our public education committee, but he has some really nice protocols and the research on medication choices, usage, and dosage that we wanted to have available for pediatricians. And then we also wanted pediatricians to know, because many of the ones I speak to say, I just can't and don't have the time to do this kind of.
Are the medication protocols in here?
It's a separate document available.
Yeah.
Yeah, and so we want pediatricians to know where they can refer if more help is needed, either to one of us as therapists or to other resources in the community online and others. So we, gave some info about, just a few of the books. And we're not going to go into this, but we also created some slides about the knowledge about functional abdominal pain, since that's what they deal with a lot. So we're not going to do that today, but you'll see it available if you wanted to use it. Some other slides about education on functional abdominal pain. And then we'll go to Deborah, because I think that's like a cool part.
Okay, show my screen. Hopefully my computer will play nice.
And Astrid, do we have much questions yet?
We'll use my coping skills if my computer is not nice to me. Let's see.
Okay.
Okay. Can you guys see that?
We won't answer them now. I'm just curious about timing, if we have a lot of questions or not.
Sure. We just had one question about whether or not you have a chance to cover how to enhance the relationship with pediatricians, which I believe
that's what Deborah's doing now.
Cover. Yeah. Awesome.
So do you guys see the presentation now?
Yes.
Tips to enhance?
Yes. Perfect.
Okay, cool. So I no longer see you guys, but if you're, when you have,
you can't see us when you're doing it.
Oh, Okay. So you guys didn't see me making faces at you guys or anything?
Nope.
I could.
Okay, so going a little bit off script, but I just have to once again compliment that. Ooh, I just lost my thingy. That presentation, and I give talks on this topic all the time, and I've kind of created my own, but I forget what a wealth of knowledge is packed into the one that ADA has created with the help of the wonderful people on this committee. And I feel so lucky as a member to have access to that presentation. And I know I'm going to be integrating a lot more into the kind of talks that I give. So we're all very lucky to have, it's really packed with all the right information that I believe pediatricians want to hear. So let me just make sure. Okay. So the topic of tips to enhance relationships with pediatricians and other providers in your community. I think what was the motivation to create this presentation is that we're all so busy these days, and I think pediatricians and other providers are no exception to that. So I think they really do want to hear about this information, and they want to meet high quality providers in the community, but for them to have the time to set up a meeting, it's not like trying to network with a real estate professional or someone in finance that it's very hard to get on their calendar to share that kind of information. And so I run a treatment center, Light on Anxiety, and I opened it with one small office, and I've been growing. So I have to think like a clinician, but also think like a business person who's trying to maintain my business. And so sometimes you have to get a little bit creative to get in the door to meet with pediatricians and other stakeholders who really would value this information if they had the time to access it. So I wish there was a way I could see you guys in like a small way. So if I'm seeing the presentation, you guys are gone. There's no.
Yeah, you just can't. Keep going. You just can't.
I just have to tolerate feeling alone, but you're there. You guys are still there.
I'm
okay.
here.
We're here.
We're here. Okay. So I spent a while trying to figure out how do you set up these meetings? Who is the gatekeeper in a lot of ways to meet with the pediatrician? And so sometimes that might be the office manager for the practice, or there's a practice manager, or there's a front office staff person. And so really each practice is going to have its own admin functions that coordinate the calendar and maybe schedule lunch and learns. And you kind of have to go in there and ask the front office desk, is there somebody who I can speak with about setting up a time to speak with the pediatricians at the group? It's often they might have a binder where they have different time slots available to host a lunch to share the information. Sometimes they'll just say, oh, you could email me directly and set up a time to speak. So I wish that there was one answer to how to connect with a pediatrician. What I found is it's a lot of trial and error, and it depends a lot on the group. And the good news is though, once you have that relationship, it grows very quickly by effectively servicing their patient population, by being accessible, by communicating. They're really, really, really looking for support in helping their anxious patients and the families. So
yeah, Deborah, I think Lynn, I think I'm just saying it's a good point. I think you only have to know one or two to three offices, and if you have good collaboration and you provide quality care, and we'll talk about how you need to get back to them as well. It's not like you have to go to 15 offices. A few practices local to you, they'll be really glad to know you exist. And if you want referrals, you will have them.
Yeah, and I was more shy at first doing this a couple years back, and when I dropped off, when I was just at my own child's pediatrician, and I was sharing a little bit about what I did, and I had some information, and they called me a couple months later, oh, can you drop off some more of your newsletters? And so I certainly know what we do is valuable, but to see that they were really getting it and so eagerly handing out the information that they were actually requesting that I come back for more made me realize, okay, you just kind of have to take that risk of introducing what you're doing. And then they're looking for tools in the toolbox to help their patients. There's no doubt about that. So other creative ways to connect with pediatricians and other providers in your community, maybe surprisingly, but I do find LinkedIn very helpful. I kind of dabble when I have in all my free time, different platforms to connect. And what I found is the healthcare providers that are on LinkedIn are, I guess not surprisingly, very interested in connections. And if they're active by reaching out that way and asking if they're if they're taking new patients and if they'd like to connect to learn more about my practice. I've met some really wonderful providers that we've set up meetings and kind of created a local community of passing referrals back and forth. So sometimes people don't think of using it, but it can be quite helpful. Lynn or Ruth, do you ever use LinkedIn for connecting with other providers?
With other providers, but not pediatricians. I would just be aware, Deborah, that you have 13 minutes, so
yeah,
I might go forward with your great ideas.
Only have like 5 slides, so, and then hopefully we'll have questions. And so this feels a little risque to say, but maybe maybe not learn from pharmaceutical companies. Sometimes I try to think, how can I get pediatricians to prescribe CBT? I love it. So I actually created, that was just a sample of a prescription pad, but I have in here somewhere prescription pads that I've printed up that I drop off with providers in my community to facilitate. Pretty much looks like the one here, CBT prescription pad, so that it makes it that much easier for them to offer the tools of CBT to their parents. Because in speaking to providers in my community, they said in such a short amount of time, sometimes even having that conversation, that it may be more stress driven, the stomach aches, and if it feels like it's going to be a big messy conversation with the family, they might be offended, they don't have the right language to discuss it, might cause them to not necessarily mention it. So to try to help facilitate their ability to offer CBT to their family community has been a nice tool that I've been playing around with. And I guess an example of a failed attempt to model what the pharmaceutical companies might do, that I would say just doing if going in sometimes to offer to host a lunch where you share your information. I've found if there isn't, not knowing ahead of time if there's going to be pediatricians or providers actively a part of it, but more just the office staff coming in, grabbing lunch, and then that was not a good use of my time or financial resources. So certainly making sure ahead of time how actively are the physicians in the group going to be attending, because once they're there, they're interested. But if they're not attending, then they're not going to get this information. So don't do what I did on that front. Another thing, joint programming. We recently showed, we showed angst with some pediatrician groups in our city of Chicago last year, and recently we showed the movie
Unstuck.
No, it's not Screen. It's by the people who did Screenagers, but it's their new movie on social media. Oh, Liked. So it's a movie called Like by the same people who created Angst. It was great, all about social media and the brain, which is certainly, and technology in the brain, which is something that pediatricians are very much interested in. So we together showed a movie at a local movie theater, and then had a panel discussion afterwards. And so they're very much looking for ways to help their families and connect on different ways, different levels also. So when you get creative, they normally are quite interested in joining as well. Another thing, I try to find fun giveaways to leave with pediatricians providers. So squishy balls, silly putty, pens. What's my newest thing? This is kind of for fun, but sometimes finding nice ways that you could leave behind your message, and also something that can be helpful. Like, for example, I have a slap bracelet that says "Be Here Now," so kind of a nice way to mindfully return back to the present moment. My business card, I try to leave tips anxiety fighting tips on there, so you're not just leaving a business card. So you could get kind of creative in ways when you only have a few minutes with a provider, with a pediatrician, so kind of make those moments as memorable as possible is certainly helpful. And continuing the conversation, so after the meetings, I found early on that you could have a really great first meeting and everyone's very excited, but like any other relationship, you can have a great first date, but it's not going to go anywhere if you don't keep that relationship going. And we're all so busy that really finding the time to send that email about thanking them for the meeting, and then maybe every 6 months reaching out. Sometimes when we get a new referral, I might even send a handwritten thank you gift note, a thank you card, and maybe even a Starbucks gift card just to thank them for thinking of us. So
Well,
really ways to foster the relationship.
Yeah, and I try every time I do get a referral from a medical doctor to really send a note, because that's what physicians do for other physicians, right? You know, for the referral, this is what my plan is to help your patient,
Right.
and you know, if you have any questions or concerns, I think that's a really important.
Right.
I totally agree with Ruth. I think that's the easy way without having to go to the offices. If you ask every client who their pediatrician is, if the pediatrician referred, you especially want to do it. But even who your pediatrician is, you could send. And my experience, again, like Deborah said, is it's different for different providers. But they want to know, one, that the family actually came to your office, and then they also want to know when you finished. Right, and they don't need a lot, but they love having in the chart, right? You know, family connected with this psychologist's 5 sessions targeting anxiety management. So they've taught me what they want. And so I don't do it as much as I should, but I try and do beginning and end of treatment, saying we've stopped for now, we've gone to as needed. You're right, I think this kid's in good shape because they have his tools, or they quit early. You know, I will just send, because I've usually gotten a release, you know, but they often want an email. Sometimes they'll just do an email to put in the chart. So you don't have to write a card. They actually prefer the email. They just print it out and put it in as the medical record. So I think that's an easy way. And I do think if you treat a few kids of a pediatrician respectfully, and the family goes back and talks about you, it's amazing. My best, I've been in this 20 years and I have more referrals than I know what to do with. I treated a pediatrician's son 15 years ago, because he's now in college and he was 6 at the time. And this was an unusual pediatrician. He told every client of his that had anxiety, my child got treated by Dr. Sickwell and you have to go see her. I hate this because it scares me, even though I think I'm pretty good. They're driving an hour each way because where that practice is not close by. And he told all his associates to refer to our practice. Now our whole practice, it's a very big practice of 6 pediatricians. We have a ton of work, and it's a great collaboration for PANS cases, sleep issues. We've actually had some really important GI follow-up where it wasn't anxiety, but I helped them figure out that we treated the anxiety part and the kids still had ongoing abdominal pain. And it led, you know, to much more intervention, but we worked collaboratively by email mostly, right? Just saying, I tried this, it's the anxiety is lower, but she's still having pain after eating. But we were able to figure out the medical intervention.
We have 5 more minutes. Let's just see if we have any questions.
Yeah.
Okay, and so just following up on the collaborative care piece, it's tricky and it takes commitment and consistency. So we really, after each new intake, we send a fax asking, how do you want to be communicated with? Do you prefer emails, fax? And what information do you want? Because like Lynn said, sometimes they just want to know that that the handoff is complete. Sometimes they want more information. So really getting that customized understanding of what they want and how helps a lot in effectively collaborating. And last point I'd make is, I think the biggest challenge for me in my practice, it was kind of managing my own social anxiety around taking risks, putting myself out of my comfort zone and walking in, I'd be like, okay, you're gonna walk in, and I'd walk by the office and not walk in, and to push myself to connect, which can be intimidating, but like anything else that we all push ourselves to do is normally quite meaningful once we face our fears. So
that's a great point.
Professional social anxiety disorder, not in the DSM, but very real.
Deborah, I love this part of the presentation. I think you are just so creative, and I love the way you have walked outside your comfort zone. And I think these are really, really helpful tips for people that want to.
Can we show that next slide about the brochure?
Right. Very importantly, we are all so lucky, as I keep saying, to have access to this material. And so this was the link as of a year ago. It might have changed, and I think Astrid did start this presentation with where to access the PowerPoint presentation, also these brochures that you can download, and you also can download without your logo, or you could include your logo on it as well to kind of co-brand yourself with this ADA initiative. And so that's sort of an example of how I access the brochure and put my logo on it as well. And so I wouldn't go with the link on this presentation, but I know Astrid had sent out how to access these tools for professional members of ADAA.
Yeah.
Okay, so that's it. So any questions?
Awesome. Thank you so much to all of today's presenters. As a reminder, you can submit all questions in the chat box on the attendee interface. I believe I have one question. Do you have any practical tips for presenting this PowerPoint? Is a laptop okay?
Oh, yeah.
Yeah, if you're in a smaller, I would say if you're presenting to a school community where there's 50 people in the audience, you'd want an overhead projector. But if you're just going into it, if it is for a pediatric practice, I would say through your computer, because there's just going to be a few people sitting around the table. And you could even have a few of the slides printed out that you think are the most important takeaways. You could print out the accommodation scale, or if there's a few things you want to leave behind, I wouldn't leave the whole presentation, would overwhelm them, but maybe have a few printouts of what you think will be helpful to them.
That's a good question. How do you present it, right? In a small environment. Yeah.
Yeah, good question.
All right. I don't believe I have any questions. Oh, I have a few that just came in. Our practice doesn't accept insurance. Any ideas of how to get to pediatricians who might be open to that?
My practice doesn't accept any insurance either. You know, it does mean that certain people can't come to you. Everybody in our practice offers some sliding scale to help with that. But I do think the one thing that pediatricians have learned working with us is 3 months with us might cost the same as 1 year with a $25 copay with your insurance. And while we can't guarantee families fast outcome or fast results, I think it is helpful for pediatricians to know that CBT tends to be a short-term treatment, not a lot of sessions, and that they might be able to present to the family. I know this is a big expense, but would it be feasible, you know, if it was this? But that's, and I offer parent workshops and other things to actually try and offer services for families who can't afford treatment without me taking insurance. That's my end.
Also, one thought in Chicago, for example, there's a few concierge pediatric groups that have opened. We do take insurance, but just thinking of what, there are some pediatric groups that don't take insurance, and they're more of this concierge model that they're really trying to be available in more customized ways to their patient population, and they certainly would understand the services when by not taking insurance. So you might want to look in your area and see if there are some of these concierge pediatrician groups.
Right. I think it just depends on your area and targeting market segment.
I also think I enjoy working with parents a lot, and some people don't as much, but I do think there's other ways to offer maybe just 2 sessions parent consultation around teaching this stuff that could make a huge difference for a family who couldn't afford treatment. And certainly Ellie Leibowitz has just put a big study out there kind of showing that parent alone without the kid ever coming in is just as effective as child CBT done right. But I have found a lot of parents, as I said, being willing to agree to 2-session parent consultation, very specific, and I don't do a deep intake. I do much more about teaching about anxiety and tools for coaching in the moments, because a lot of people can do a lot with that. So that might be another way to, and then if they get to know you, they might bring your kid in. That's what I also find too, right? If they find you're worthwhile, the parenting part, then maybe they're willing to help pay for some sessions, you know, with their child. But some families can't afford it. I mean, can't afford a private practice, that's for sure.
Okay, we have one more question. It seems that meeting at a pediatrician's office would not allow time for all the doctors to be present or to do the whole slideshow. Where can I find meetings of pediatricians to present this to?
Well, I think, you know, one of the things we thought about while putting together this PowerPoint presentation was that you don't have to show the whole PowerPoint presentation.
Right.
You can really pick and choose, and that's why we put it into segments. And, you know, I think that you talk to the pediatrician's office, you get a sense of what's most important to them, and you pick and choose based on there. And we purposely did the presentation so it's in segments and
in chunks, right? And the public education committee is working hard on actually getting this out to pediatricians overall, and we actually are working with ADAA to consider having it available to view in segments by pediatricians directly from ADAA on our website. So we're all working on ways to get it out there. So you could also, you know, let people know this is available to watch on your own time, but could I come in and answer any questions, right? Or you can follow up with me with questions. Most pediatricians' offices do a monthly staff development meeting. That's where I've presented either a short or long presentation. They don't all want you, or they're booked for the year, but it is worth asking. And I try and tailor my presentation to their interests. So I said, I'll present on anything that I know for you, like sleep, hands, right? Belly pain, you know, mindfulness in kids. So I think you actually can get sometimes meeting with all the pediatricians at their staff development, but it's only like once a month, you know, usually.
It sounds like the participant was asking, is there a way to kind of like a local pediatrician group where you could kind of access all pediatricians from different groups? And I have yet to find something like that where where we would all be at ADAA if someone wanted to reach us that way. Oh, sorry, it's a little loud background noise, but I've found more of the one-offs are the easiest way to connect with pediatricians versus if there's a local Chicago pediatrician networking group that I could just go and meet with all of them. That's not something I've found exists.
But you could ask pediatricians in your area, do you have local groups?
Yeah, but that's a really good idea to ask local pediatricians what is the best way to further network with your kind.
All right. Do you think we have time for one more question?
Sure.
Yep. Okay, sure. Somebody said, I love that idea, Dr. Sicklin. Do you do the parent consult one-on-one or in a group format? Also, do you follow a specific protocol?
People will see it on ADA webinars. I've been offering parent workshops in a group, small groups, 8 to 10 parents for about 3 or 4 years. It's one of my favorite things that I do. So I do both. I do individual if parents want to ask for a consultation about how to parent their child and assess the need for treatment and ideas. But I also do parent workshops, and I've created a workshop that I like. If anybody wants to contact me, I've actually made it available online, 2 45-minute versions of I do 2 2-hour parent workshops, and everyone likes it and comes for the whole hours and wishes it was longer. So I don't have trouble people coming for 2 2-hour workshops 2 weeks apart. That's how I do the parent group one. But I do have a 45-minute version of each 2-hour available for $25 that I could I'll send to you guys for free, but just let me know. But I really wanted to get the info out there. And there's some other very good parent workshops. Ruth, you know, I'm blanking on her name, the woman we wanted to invite to ADA conference, Lyons?
Lynn Lyons.
Lynn
Yeah.
Lyons has a very, very good parent protocol info that I love, and Ruth loves, and is a lot like we all. It's a lot like we all work. That's great. So there's actually some very good ones out there.
All right, I think that's all the time we have for questions. Thank you so much to today's presenters, and thank you to our participants for attending today's training. You will receive an email shortly that includes the link to the webinar evaluation, as well as a link to the recording of this webinar. For those seeking CE credit, the post-test assessment will be distributed after these few announcements. The post-test assessment will also be included in a follow-up email for anyone interested in completing at a later date. All right, thank you so much, Dr. Kissen, Dr. Sicklin, and Ruth.
Thank you.
All right.
Thanks, Astrid.
Great, thank you.
No problem.
Thanks. Bye-bye.
Bye.
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 Our next ADA Live webinar, Using eHealth to Increase the Reach of Evidence-Based Treatments for PTSD, Lessons Learned from the Web PE Studies, featuring Carmen McLean, will take place Thursday, May 23rd at 12 p.m. Please visit ada.org to register today. If you're not yet an ADA member, we invite you to view the many membership benefits that ADA has to offer. Please visit ada.org to learn more. On behalf of ADA and our presenter, we thank you so much for joining us today. You will now have the opportunity to complete the post-test assessment for today's training. You must have registered for this webinar with CE credit, obtain a minimum 80% or higher on the post-test assessment, and complete the webinar evaluation with the 4 provided for letter codes in order to be eligible for CE. If you did not receive a score of 80% or higher, please email webinars@ada.org. I will now launch the post-test assessment. You may exit the training once complete.